conference on opportunities for digital healthcare, lessons learned from the COVID-19 pandemic. Although a few people are still logging in, we're going to go ahead and get started on time. I'm Arlene Bierman, and I will be moderating this webinar. I currently serve as the director of the Center for Evidence and Practice Improvement at AHRQ. This slide shows the agenda for today's webinar. Please note that we are recording this webinar and that the recording and slides will be available on the AHRQ Digital Healthcare website in a few weeks. You will be notified by email once they are available. And we're pleased to have a really terrific panel today of esteemed presenters, and they include Dr. Jerome Osheroff of the AHRQ COVID-19 Collaborative and TMIT Consulting, Dr. Alex Krist from Virginia Commonwealth University, and Dr. Robert Rudin from RAND Corporation. The webinar event is accredited by Affinity CE. For those of you who are interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations, and it will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, TISTA, Affinity CE, and the panelists have no financial interest to disclose. Lastly, please note that no commercial support was received for the development of this learning activity. Now I will hand it over to our web conference coordinator, Amal Saeed, with TISTA, who will explain some of the logistics. Amal?
Thanks, Arlene. Just a brief note about questions. We've reserved time at the end of the presentations to address any attendee questions. However, during the presentations, feel free to submit any questions you have via the Q&A panel. You should see Q&A towards the bottom right of your screen. If you expand and hit the arrow key, it will open up the box where you can submit questions. Please include the presenter's name or the order of their presentation, first, second, or third, with your questions so we can help identify them at the end. As a reminder, all participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of the presentation, you should be able to, 1, explain the challenges and opportunities to improve the evidence to guidance to action to data to evidence learning health cycle with digital healthcare approaches and tools, especially related to putting rapidly evolving evidence and guidance into practice for novel infectious diseases. 2, describe a model for engaging patients in care planning to facilitate decision-making and discuss facilitators and barriers to implementing patient care planning. And 3, describe how digital healthcare technologies that support gathering patient-reported outcomes can be used to improve patient empowerment and patient-driven care, and how these technologies have been adapted to face the needs presented by the pandemic. And now back to Arlene, who will introduce the first speaker.
And now it's my pleasure to introduce our first presenter, Dr. Jerry Osheroff. Dr. Osheroff is a general internist by training, is a principal of TMIT Consulting, and a leader in driving care transformation. He chairs the AHRQ Evidence-Based Care Transformation Support Acts initiatives, stakeholder community, and led development of the draft Acts roadmap for producing a knowledge ecosystem that broadly fosters learning health systems and their successes in realizing the quadruple aim. As part of this role, he is leading the Acts COVID-19 Guidance to Action Collaborative, which is driving progress toward this knowledge ecosystem in ways that improve care delivery and outcomes related to the current pandemic and beyond. And now allow me to turn the control over to Dr. Jerry Osheroff.
Thank you, Dr. Bierman. Greetings, everyone. I'm really excited to be here with you all today. I hope you'll take away from my presentation helpful information about how we can leverage digitally supported healthcare approaches to ensure that information flows in ways that create learning health systems that continually improve care delivery and outcomes. That is by improving how we process healthcare evidence into clinical guidance, put that guidance into action, gather and analyze data about the results from those actions, and use those data to create new evidence in what we call the learning health system, or LHS cycle. The COVID-19 pandemic has dramatically intensified the focus on leveraging digital healthcare approaches to put rapidly evolving evidence and guidance into practice, and we'll also discuss efforts in this area specifically. Next slide. This cartoon highlights that the LHS cycle today isn't very efficient or effective. It's difficult and time-consuming to gather and synthesize evidence on a particular topic like blood pressure control or many others. For example, produce guidance and tools based on that evidence, use them to support care decisions and actions, and gather data about care processes and results in ways that feed back into enhancing the evidence base. The information and tools that drive each step are hard to find, integrate, and use, and the output from each step in the cycle doesn't flow smoothly into the next. Next slide. The slide before this, I'm sorry. Yeah. These problems have been known for a long time. For example, that it takes way too long to get from when we have solid evidence that a particular care intervention, such as a test, a drug, or other treatment, is valuable for improving morbidity and mortality, and where that intervention is widely used as appropriate based on the evidence. There are various reasons for these inefficiencies within and between the LHS cycle steps, including barriers like inadequate business drivers, standards, and coordination needed to make the whole cycle work better. Needed information at each step in the cycle is also often missing or hard to manage. The COVID-19 pandemic made tens of millions of people sick and killed millions around the world quite quickly, and that shined a bright light on the life and death consequences of the silos, gaps, and inefficiencies in the LHS cycle for this condition, and created urgency and momentum to make the cycle work better. Next slide, please. About a year before the pandemic began, AHRQ launched the AHRQ Evidence-Based Care Transformation, or ACTS, initiative to produce a stakeholder-driven roadmap for making the many valuable resources AHRQ produces, which together support all the LHS cycle steps, more FAIR, which stands for findable, accessible, interoperable, and reusable, and also more computable and useful. In 2019, a large and diverse stakeholder community and several work groups were assembled to create a shared future vision for evidence-based digital healthcare enabled LHS cycle flow that optimizes the use of information and tools from AHRQ and other public and private suppliers. Based on that consensus future vision, a high-level path was outlined to broadly realize that vision. In response to the pandemic, these efforts refocused in March of 2020 into forming a collaborative to help the participating stakeholders respond to the pandemic. Next slide, please. This slide gives a flavor for the diverse and interdependent groups that ACTS stakeholder community participants come from. So far, there are over 330 people who've asked to join this effort, and a sizable fraction participated actively in defining the future vision and approach to realize it, and/or are effective participants in the ACTS COVID collaborative. Next slide, please. The foundation for the consensus future vision is having all the evidence, guidance, and tools that make up the disconnected puzzle pieces and gears on the first LHS slide I showed work together efficiently and effectively. The goal is to produce a robust, stakeholder-driven digital healthcare knowledge ecosystem. This knowledge ecosystem supports an LHS cycle where each pass around the loop generates continuously better knowledge, care, and outcomes. This delivers what's known as the quintuple aim, which means simultaneously improving health, experiences for patients and care teams, reducing costs, and achieving health equity. Next. In early 2020, stakeholder community participants were exploring potential pilot initiatives to drive progress toward this future vision. In March, the conversations naturally turned to how stakeholders from care delivery organizations, health IT suppliers, and many other stakeholder groups were responding to the unfolding pandemic crisis. AHRQ then supported forming the ACTS COVID-19 Evidence to Guidance to Action Collaborative. The collaborative goals include cross-fertilizing and accelerating participants' efforts to produce and use evidence-based guidance and tools for managing COVID-19 patients, improving care and outcomes for specific targets and settings in ways that could be broadly scaled to many other targets and settings for COVID and beyond, and do this in a way that helps lay the foundation for the patient-centered knowledge ecosystem needed to realize the future vision. Next. This figure shows in more detail the activities around the LHS cycle that the knowledge ecosystem needs to improve for healthcare challenges like COVID-19. These steps include producing evidence-based guidance on the clinical target that informs tools for putting that guidance into practice, and then disseminating these tools so they can be integrated into information systems and workflows that support care, and so on around the cycle. A key point is that at each step, the underlying information is computable and interoperable. In other words, unlike the current suboptimal LHS cycle, the puzzle pieces representing the current representing information and tools all fit together smoothly, and each gear representing an LHS cycle step efficiently drives the next step. Next slide, please. Using the analogy of maps for navigation helps clarify the important role that computability and interoperability play in producing the desired knowledge ecosystem and LHS cycle. Printed maps are a powerful tool for getting from one place to another, and this power was dramatically amplified when maps were digitized so that many maps could be accessed quickly and easily. Another leap forward came with software that made the information in maps executable in ways that provided turn-by-turn guidance. The next leap came when the maps became more computable and interoperable in ways that enabled richer functions that work across platforms, like updating the guidance in real time based on current traffic and road conditions. Next slide. Clinical evidence and guidance are, of course, undergoing a similar evolution. Journals, textbooks, and other printed tools for education and supporting health decisions and actions were first digitized, enabling vast amounts of information to be accessed and distributed much more easily. An explosion of healthcare-related apps and software tools has made this information executable in ways that support patients, care teams, and others, but like early navigation tools, they're dependent on specific platforms, and information doesn't flow easily from one tool to another. We're in relatively early stages now of making evidence, guidance, and related information more computable and interoperable. As with computable navigation tools, this will make it possible to provide the most current evidence-based knowledge and tools more easily than is practical now. And like with navigation, the result will be decisions and actions that are supported by the latest information and guidance. Next slide, please. Getting back to the ACTS COVID Collaborative, over the last 18 months, members that deliver care or support those delivering care have been using available information and tools to address specific COVID-related targets within their organization. This slide gives a sampling of the care delivery organizations, or CDOs, and targets they're working on. The CDOs include academic medical centers, big health systems like the VA, and health centers. Individuals from organizations that support their work, such as health IT suppliers, federal agencies, quality organizations, and others, also participate in this learning community. The COVID targets of particular interest range from triage to acute care to chronic management. Next slide. For each target, the CDOs want to ensure that the care policies and decision support they provide remain current. This requires tracking what the latest patient management recommendations are, when important new evidence is published, and when that triggers changes in recommended care. They then need to filter that information into creating or updating policies and decision support tools that help put that guidance into practice. Collaborative participants are sharing strategies and tools they use to address these needs and many others around the LHS cycle. For example, developing reusable, interoperable decision support interventions and performance measures for the targets, implementing these interventions successfully so they're used and useful, and gathering data about care results to support quality improvements and creating new evidence on these topics. Next slide. Collaborative participants are using the project website, weekly and other ad hoc meetings, and other channels to share their strategies, challenges, needs, and tools related to this work. The goal is to enhance their results on the current targets and efforts of interest in ways that can be scaled to many other organizations and targets. A central collaborative focus now is producing an art of the possible LHS concept demonstration that illustrates how digital healthcare approaches that leverage computable evidence and guidance and interoperable tools could drive major improvements in LHS cycle function. The specific clinical targets that underlie this concept demonstration are driven by targets of interest to collaborative participants and many others. These include long COVID, anticoagulation for hospitalized COVID patients, and 2 non-COVID conditions, cancer screening and hypertension control. In addition to providing a compelling patient journey that shows how this future state will be experienced by patients and care teams, the concept demo will outline needed tools, infrastructure, and enablers to broadly realize this vision for many targets. Next slide, please. This slide outlines a couple of the tools that are featured in this concept demo. For example, a mock-up that could become a working tool soon to help answer the question, is there new evidence and guidance that should potentially trigger a change in our clinical policies and CDS interventions for this target? And a related tool that could be developed when computable evidence and guidance are available that would automatically find, organize, and update that kind of practice changer information for a target and present it for specific patient subpopulations, such as a particular age group or pregnancy status. Another tool set that will be featured in the LHS concept demo will illustrate how shared comprehensive care plans that support coordinated evidence-based care and the LHS cycle. This part of the demo will leverage work on e-care plans led by AHRQ and NIDDK, as well as a related ACTS project that Dr. Krist will describe in just a moment. Next slide. This slide is an overview of the art of the possible tools that will be included in the concept demo, either as storyboards, clickable tool mock-ups, or actual working tools, and how they support each of the LHS cycle steps. We plan to have a draft of the concept demo available for public review by September. Next slide. The path to achieve the ACTS future vision has 5 core elements, and the collaborative's work, culminating in this LHS concept demo, is beginning to address each of these elements. They include cultivating and leveraging collaboration and coordination across many diverse stakeholder groups, defining needed enhancements to ecosystem cycle infrastructure, exploring, creating, and applying computable evidence and guidance for high priority targets, surfacing successful strategies for guidance implementation, and preparing for evaluation and scaling of LHS related efforts. Next slide, please. As I mentioned, hundreds of people have asked to participate in the ACTS stakeholder community, and a major fraction of them are actually actively engaged in the collaborative efforts I've outlined. We've already received support letters from 36 organizations across different key stakeholder groups indicating plans to collaborate and align their strategies and investments to drive progress toward the shared future vision. This slide has links to the actual letters, which come from federal agencies, care delivery organizations, professional societies and accrediting bodies, health IT suppliers, standards organizations, clinical evidence and guidance organizations, and patient advocates. In other words, sort of a smattering of the core group that's going to be essential to make this future vision happening. We're hopeful that this engagement, together with the springboard for action The concept demo aims to produce will foster the support from a broad range of stakeholders needed to fully realize the knowledge ecosystem in quintuple aim. Next slide, please. For all the horrible things COVID-19 has done, the remarkable way so many people have risen to the challenge highlights how much faster we could move to make the urgently needed LHS cycle improvements. We need to build on the type of collaborative work I've outlined so that we can produce evidence-based guidance and put it into practice effectively in a continuously improving manner. It's already a matter of life and death for COVID and many other conditions, and we need as much progress as we can make before the next pandemic. Next slide, please. This slide, in conclusion, has some takeaways from this effort that might be helpful in your work. For example, there's great interest from many stakeholders in broad collaborations that can be leveraged to enhance different parts of the healthcare knowledge ecosystem in a coordinated fashion. Providing rich collaboration infrastructure and opportunities has been very helpful. Positioning this whole initiative as a means to advance participant goals rather than as will you help the government with this project has been a very fruitful approach. And finally, we need to extend the strong focus and investments on making patient data computable. For example, the billions of federal dollars spent to help spread EHRs to make knowledge computable and interoperable. Next slide, please. We would love to follow up with you, and here is my contact information and the collaborative website URL.
Thank you, Dr. Osheroff. As a reminder, we will be taking questions after all of the presentations have been completed. So please submit any questions you have using the Q&A panel. Next, I will turn it back over to Arlene.
Okay, so I'm really pleased to introduce our next speaker, Dr. Alex Krist. He's an active clinician, teacher, and researcher. His busy clinical practice is a VCU family medicine residency practice, and it's a dynamic community-based center of research activities. His specific research interests focus on practically combining informatics, preventive care, evidence-based practice, patient education, shared decision-making, community care, and patient-centered care. And now I'd like to turn it over to Dr. Krist. Welcome.
Thank you so much, Arlene. I appreciate it. And Jerry, that's a nice lead into things. I'm going to talk some about the work that we are doing on care planning and really trying to get information to patients when they need it. I'll relate some of this back to the responses to the COVID pandemic. But you'll see a lot of the care planning work we were doing was around cancer screening. We were trying to kind of maintain ongoing preventive and chronic care and contact with our patients during the pandemic. And the principles I'm going to talk about can be applied to many different aspects of care, including public health responses to a pandemic. So we're going to talk a little bit about some of the work we were trying to do about making guidance computable with interoperable standards, engaging patients in their information, and then sort of what's working and not working in the process, and what can we learn from to try and take it the next steps, both kind of locally in our own systems and then on a national level, so that we can really have the infrastructure in place to do this better when we need to. So going a little bit to Jerry's talk about sort of what does a better world look like? If you imagine, information systems should be able to kind of anticipate people's information needs. In this case, we're going to be focusing a little bit on decisions that they might have to make, getting them the right information at the right time, and then helping to guide them through using that information so that they can make plans and act on taking care of themselves. And then a lot of this can be automated and integrated into care and workflow, and this can help both the patient and the clinician and sort of the whole decision-making care delivery process to be more efficient and more in line with individual people's needs. If you haven't seen this document, or this report, recently the National Academy of Science, Engineering, and Medicine came out with its report on implementing high quality primary care. And there's a section in the report on digital health. And the digital health section really is in alignment with the things that we're talking about today. And the committee very simply broke down digital health into 4 basic functions: collecting information, aggregating information, analyzing information, and then applying it to care. And you can imagine that different approaches that we would take might involve lots of different information sources coming in. Some health systems were trying to get remote monitoring at home for patients, oxygen levels, EKGs, trying to collect patient-reported information, and then sort of automate that process of bringing it all together, aggregating it, then actually applying some analysis to this so we can make sense of the information, and then using it to deliver care that will help people. I'm going to relate this process back to some very basic cancer screening decisions, kind of show some challenges with this, just to kind of demonstrate what we need to be working on building. This is a model we've been thinking of for patient information systems that are more patient-centered. And the idea is that you need to combine clinical data. Patients can't remember all their clinical data. There's ridiculous amounts needed to guide care. But then you also have to combine that with patient-reported information. There are many things like health behaviors and how people are feeling and their values that just aren't in information systems. That's part of that collecting information phase, and then aggregating it. And then the next parts of the models we say is that, for making information usable by patients, we have to do something to interpret that information. Just merely showing patients their med lists, their lab results, things like that, this doesn't help to guide and inform people. So interpretation needs to occur. And then it needs to be translated into lay language. And then that last step is making it actionable. That's the whole application part of that National Academy report, and how digital health can be applied to delivering care and making people healthier. This is a platform we've been working on for more than a decade now. My Preventive Care application built into patient portals, where we're trying to combine patient-reported information, clinical information, then apply all that information to guidelines that are out there so that we can make sense of this information, translate it into lay language, and give it back to people so they can act on it. We've done pretty well with collecting the information, applying it to guidelines, and translating it. We've not done as well with kind of that last step of using it to deliver care. And that's some of what we are working on here in this that I'll talk about today. I'm going to talk about a prior experience pre-pandemic. We'd created some care modules around cancer screening and sent this out to more than 10,000 patients. About 10% got engaged, used these different types of models prior to care in office visits, and shared the information with their doctors. One of the things that was rather terrifying to me is we were just looking at 3 cancer screening decisions, breast, colon, and prostate, and sending it to patients who'd be making a decision. And it's the specific groups of people who need to make a decision. And out of that 11,000 people, 1 in 5 patients needed to make a decision. It gives you an idea of the information burden that's out there, and how much work we need to do to get information to people at the right point in time. Now, part of this process was looking at how did this impact patients' care delivery, and where were they at with the information journey. That was part of our study and what we were looking at. And quite interestingly, for these 3 cancer screening decisions, well, half of the people had already made a decision. So that also highlights kind of knowing where people are at and what they're thinking and what they're believing is part of an important part of this process of sharing information with people. And then the next box there is about how are people making decisions. And we kind of weighed this by, are people making gut decisions, or are they weighing pros and cons and science and evidence? Most people actually wanted to weigh pros and cons and look at the data and have this information. But then there's a little element of gut feelings in making decisions. And then what do people want to do next? They want to talk with their doctor. I think that was an area during the COVID pandemic where the health systems that I work in had the greatest success. It was really around telehealth and digital platforms that allowed people to kind of still connect, work with their doctor. And that process worked a lot better than trying to kind of automate sending prepackaged informations to patients. But that also worked as well. Here are the types of things that people said looking at information beforehand and in preparing for their doctor, how it helped them. It changed discussions. It brought things up. It even made patients feel like their doctors were more sensitive to their needs. Certainly improved patient knowledge and improved communication. So we took this actually as part of this ACTS work before the pandemic, but then during the pandemic as well, and tried to say, look, one of the limitations we've had is it's not been widely disseminatable. Can we kind of make this more disseminatable and think about this model on how we get people information? And we really had these different steps in this model to think about this, about some type of automated triggers to identify people who have information needs, some type of mechanism to send them the information and allow them to review evidence-based prepackaged information that's out there, then getting them to record some elements of where they're at, and then sending this back to clinicians to promote action. And it requires a trigger. In this case, we used pending visits and decisions, whether they were in person or virtual visits. It requires educational content. Is there material out that we can share with people? And then it requires an action step, like informing the clinician. So thinking a little bit about interoperability and what will it take to do this on a national level, we have to have these evidence-based recommendations. And if you look across guidelines, there are a lot of differences that people complain about, but there's also lots of core areas where we know basic things that improve health that people aren't getting. So there's a lot more rooms for agreement than disagreement. Need to translate it into computable format. Just as a way of background, I had the fortune of serving on the U.S. Preventive Services Task Force for years. But even looking at the guidelines that the task force makes, it's kind of difficult to translate some of these into a computable format, because you have to be a little bit more concrete about this or this and if this. So you have to make some decisions and apply them, but you can actually use that to the patient-centeredness and sharing of information to kind of deal with some of those fuzzy areas of guidelines. And nowadays, with the Cures Act, we have a lot more tools out there, like FHIR and CQL. So CQL is the clinical quality language, where you can kind of program a lot of the different information in here, and it can deliver bundles of information, and you can really change how we're doing information technology to be much more client side, which would be more patient centric, as opposed to server side and embedded just in EMRs and servers and health systems. And then you need evidence-based content for action. So when we work with our practices, we decided we try this with prostate cancer screening, mainly because there was consistent agreement, there was an easy trigger for action, and we had material publicly available. So the task force has a conversation aid, they have a video. So we wanted to pilot this and field sharing this with people. And we took our My Preventative Care platform and really tried to make this in a disseminable prototype using FHIR, using CQL, and moving to that client side instead of server side application. And with these different functionalities, it's actually quite easy these days with some of the new changes to the electronic health records to access patient information without creating custom integrations at each site, which is what we are trying to do. So from a patient experience, they would just log into the My Preventative Care app, and they would use their normal username and password that existed within their patient portal, and then the app could use the FHIR protocols to access the information, process it, and give them some directions. Now, long term, this can be applied to lots of other different issues, not just these cancer screening decisions. This is how it looks as a patient authorizes access to the app. And then we would show people very basic information to kind of highlight decisions and things that they might need to be thinking about, give them this prepackaged information, in this case, the video from the task force or a link to the CDC website where they could either watch a video about the information or read information. And then they can start to enter where they're at and what they're thinking. And this was based on some of the evidence that we had gotten in the past from clinicians and patients about what would help them most, and the types of things of where they were with making a decision and how comfortable they were with making this decision. And clinicians use that to kind of change the conversations. Now, in our pilot, we had a small number of users that we had use this. We weren't able to implement it on kind of a system-wide scale. and I'll show you why in a second, but we're trying to move towards that. About a third of people went and accessed the material, and then about only 10% of those individuals actually finished answering all the questions. But most of the folks went through and looked at all the information and just didn't complete the question process. Now, some of the feedback from clinicians, both in designing this and thinking about this model of care in general, which, as I've said, can be applied to lots of different domains of care, including acute care, such as with the pandemic, is this idea about anticipating decisions and preparing patients was something that was considered highly valuable. I span two different health systems, both of which are really trying to think through how do we shift information and decisions and actions to be outside of visits, in particular before visits. There's a little time during the visit and then following up after the visit where most of that action is going to occur in these other settings. They felt prostate cancer was an important topic, and we used this because there was this really easy information to package and share. But they said, this is not the most important thing we're dealing with now. Completely understandable. But they talked about, even for more broadly expanding cancer screening like lung, colon, breast, that would be highly valuable in this more kind of comprehensive, holistic package as they're thinking of caring for whole people as opposed to specific conditions. And then when the information came through, or where they were able to see this both in the prior trial and in this pilot that we were doing, they really talked about how this made their time more efficient and made decisions easier and higher quality. But that low use made it harder to integrate. And that really highlights an important change that I'll talk about in a second. So we have our next iteration that we're fielding, and this next iteration really is addressing those multiple cancer screening decisions. And we're going to apply this same model to other types of things like long COVID follow-up and other types of actions. Some of the key lessons that we left, though, with this is that this is really very technically feasible. So with the Cures Act, as I mentioned, there's lots of things that are making this more interoperable. But even on a more simple level, practices can take their existing infrastructure and their portals and identify patients and send them information just proactively. And we did this throughout the pandemic. So very early on, when it came to thinking about, well, what do I need to do for testing? We would launch educational campaigns and send that out to all of our patients through MyChart. Now that did miss our patients who don't have access. So that is a concern about creating some inequities with care. But then as the pandemic transitioned more from initially thinking about, well, do I need to worry about my symptoms or how do I get tested, to then how do I get vaccinated, we employed these same systems to kind of proactively reach out to people outside of just the face-to-face one-on-one contact and get people information to act and make decisions. It's also very feasible from the pandemic work and from the cancer screening work, we can anticipate some of these decisions, whether it's something in a person's clinical history or whether this is something that's going on in the world around us. We can have some ways of figuring out who needs information and get it to them when they need it. And there is material available to share with patients. Now, while there is material, it highlights a big national issue. This material is hard to find, and making sure that you're using the most up-to-date evidence-based information is difficult. And that's definitely a trouble with the pandemic when we're trying to learn how to care for people while we're creating information and we don't even know what to say is the right thing to do. That limits information we can share with people, but we can acknowledge that. But even in this case with cancer screening and having been involved with developing the decision aid in the video, it's still hard to find on the U.S. Preventive Services Task Force website unless you know where to look. But this also can be integrated into care. But what this highlighted is what we need. And a biggest one here is that cultural shift of making this the norm so that patients expect this, clinicians expect this, they're preparing outside of visits. It becomes the standard of the normal part of care. So clinicians know to look for this information. Patients know to start doing this kind of preparatory and out of visit work. And having more personal engagement approaches. So in our pilot, we just told people go log into your My Preventive Care account. They had to navigate down to the information to find it. So we're exploring having much more targeted personal engagement approaches here, which is probably also important. And linking to that doctor-patient relationship can help with that. And this highlights the national needs. Having this evidence-based material to share that's updated, easily identifiable, dependable, kind of maybe even a national indexing system to share this information. Having an ability to automate reaching out to people. So as we make this more personal in my preventive care, we are struggling within the current EMR infrastructure of automating the trigger to send things to people. A lot of times it is relying on clinicians and staff to do something to send it. And then it's very hard to send information back into systems for clinicians that don't fit in with our normal structured clinical data like meds and diagnoses and things. And this is much more important when you're starting to talk about kind of patients' perceptions and values and how they're feeling. We don't have an infrastructure for doing that right now. I think this is probably a good time for me to end here. I'm also happy to take email questions and other things. I'm going to make Rob the presenter and turn things over to him now.
Great. Thank you, Dr. Krist. Just a reminder for all attendees who are interested in asking a question, please use the Q&A box to submit the question, and we will get to those at the end of all three presentations. And now back to Arlene, who will introduce our next presenter. Arlene, are you on mute?
Sorry.
Okay, we can hear you.
Yeah, so I'm really delighted to introduce Dr. Robert Rudin from the RAND Corporation, where he's a senior information scientist. He researches digital health innovations with a specific focus on clinically integrated interventions. He conducts user and systems needs assessments, designs and implements patient-provider interventions, and evaluates impact. He previously worked as a software and applications engineer. So I'm looking forward to your presentation, Dr. Rudin.
Thank you. And I'm very eager to share with you our experiences in this journey developing and implementing a digital remote asthma symptom monitoring intervention, which we initially designed and started implementing and scaling not during a pandemic, and had to make some interesting changes in order to adjust for the pandemic. This is, I think, somewhat similar to Dr. Krist's presentation in the sense that this is another type of clinically integrated informatics intervention. Would like to acknowledge and thank AHRQ for funding for this, this work. So the presentation goals, which were described at the beginning, was essentially first to describe our initial attempt, what we've been trying to do for a few years now of taking a digital health technology. This is a smartphone app that gathers patient-reported outcomes and use it for patient empowerment and patient-driven care, and then how we've had to pivot and make some adjustments in light of the reality of the pandemic. So we began with the observation that, for the most part, patients are essentially on their own between visits. So they might go for a visit, then get some instructions, be able to access their portal, but they don't have any, it's really up to them to decide if they need to call the doctor or nurse or to decide what to do. Their visits are what, 15 to 30 minutes, sometimes a little longer. Most of the time they're not at the doctor's office. So we set out to say, well, what if there was more check-ins that could happen? What if we could implement something like this, design it in a way that where it wasn't overly burdensome on the healthcare system or the patients? So this is our initial concept for remote monitoring. So we began this with asthma. We're still working on asthma, and asthma is a great condition to start with. And the reason is that it is very prevalent. That's one reason. And there's also, it's costs a lot. And probably the biggest reason why it's appropriate for remote monitoring is the guidelines are actually very clear. They say monitor symptoms. But in reality, most patients don't monitor their symptoms effectively on their own, and they don't really have the tools to do it are supplied by their clinicians. So we set out to develop a scalable intervention to monitor asthma symptoms using patient-reported outcomes. And we started this a few years ago with a feasibility trial in specialty care, in pulmonology. This is work we've conducted with Brigham and Women's Hospital. And you can see these are some screenshots from our previous incarnation of our smartphone app. We gave the app to a bunch of patients. It was a very simple app. They answered 5 questions every week about their asthma symptoms, the standard PRO questionnaire. And if their symptoms met certain criteria, then we offered them the option to request a call from a nurse in their clinic. Or if their symptoms were really problematic, then we just called them we didn't give them the option, we just called them. And this was developed out of a user-centered design process with doctors and patients. We also had, at the time it was not feasible to integrate it into EHR directly, but we did have a manual process for pasting it in. You can see this is all fake patient names. We had a dashboard where we had the nurse able to access and see the patient's data. And just to jump to the results of that feasibility trial, we found higher adherence than what we were expecting, and this was not a random sample of patients, but at least served as a proof of concept over a 6-month study, and this is normalized by study week at the bottom. Most of the patients answered the questions. We had a good number of patients who didn't miss a single week, and when we talked to them afterward and asked them, they basically said, well, it was pretty easy and pretty helpful. One thing that's interesting that we learned is if you look at the bottom of this, we had these 3 types of callbacks, like one where they could decline a callback where their symptoms were problematic, but they said, no, I don't need a call. Another where they requested a call. They said, okay, yep, my symptoms are problematic, please call me. And then the last one was where we didn't give them the option. And when we talked to some of the patients at the end, they all hated that option. None of the patients liked that, even though in the design sessions, they said that it would be good to do. But a lot of the patients said that other patients might like it. So, this is why you do studies like this, feasibility trials. So that's clearly not a critical feature, and we did disable that going forward. Now, when we talked to the patients and the doctors afterward, we learned some interesting things. The patients were generally very positive about the app. They said they became more aware of their asthma. We weren't really designing it for this purpose, but they did feel more connected to their provider because of the check-ins, even though the provider wasn't really doing anything different. Few providers even noticed that the intervention was going on, but the patients still felt more connected. They thought the app was simple. The clinicians found that it was minimal additional work required, even though it wasn't. That was partly because it wasn't that well integrated. We didn't notify them very well in the EHR. But they did believe it facilitated triage when they talked about it with their patients. And the few that did manage to look in and see the data did think it informed their conversations during visits. We did learn that there were some critical enhancements that were needed. So some patients, not very many, said that they tracked their peak flows, and if the app didn't support that, then they wouldn't be able to use it. That's only a minority of patients, but for those patients, peak flows were were critical. The same was true for notes and triggers. And some of the patients have very well-controlled asthma. We've learned that a lot of patients actually have pretty well-controlled asthma for a long period of time, and then they start to have trouble. And for that long period of time where their asthma is stable, 5 questions once a week is actually kind of a lot. So we considered that when we're in the next phase. And of course, like for the clinicians to actually be able to access the data, it needed to be better integrated into the EHR. So we then moved on to our next stage, which was to scale and spread it to primary care. For this, we used this very helpful framework. I don't know if people are familiar with it, the NAS framework. And I think of the different frameworks I've looked at for designing and implementing digital technologies, one advantage of this is that it's specifically designed for digital health technologies or health technologies, but it's very applicable to digital, to the digital world. And they have a list of all these domains, and the big message from this framework is to keep it simple. Because in any of these domains, in terms of the intervention or the context, additional complexity reduces the odds that it will scale, and it could fail at any stage. It could not be adopted in the first place. It could be abandoned. It could not scale up properly. It could not spread, and it might not end up being sustainable. So we spent quite a bit of time thinking about all of these domains, especially the adopters, and keeping the staff roles minimal, the staff changes in staff roles minimal, but also like value proposition and the organization, and as many of these as we could. And the next version of this, so for primary care, these are some screenshots of our newly defined app. So you can see on the left, we only ask one question for patients who have stable asthma. So one question once a week is pretty minimal. If they have symptoms, then we ask them to answer all 5 questions. And then if their symptoms are, say, severe, then we tell them and give them the option to request a call from a nurse. We have some ability for them to see, and I don't show it here, but we have a graph of their symptoms. And if you can also see, we added, I don't show all the screenshots here, but we have peak flows and notes, and we added some educational materials in there, especially that were requested by the PCPs for things that they have to explain over and over again to patients. They thought that would be beneficial. And from the clinician side, and this, I know this is, the font is not always that easy to read, but essentially the thing to notice is this is a tab that gets added in Epic that says asthma data. So once it's added once, it's all set. It's ready to go for all patients. And any patients who have data here, and this was all designed through user-centered design with input from clinicians. There's some text that they can copy and paste into their notes. They can see the graph, easily see the graph, and then if they want more details, there's some guidance in the upper right, general guidance, and then a link to more detailed guidance that was developed by some of our asthma experts. One thing that I want to show that's interesting is you can see like higher on this graph means is red, so that's more severe. We actually conducted a survey of our PCPs, and we said, well, which do you prefer? Should higher mean worse asthma, or should higher mean better asthma? Because in our design sessions, we were hearing opposite preferences, and it was pretty much split down the middle, 50-50, which suggests that we have a ways to go in terms of creating standards for this kind of thing. So I want to talk a little bit about under the hood. This is really kind of the informatics nitty-gritty. Now this explains the techie side of it, which we worked on very closely with people at Brigham and Women's Hospital. Especially the site PI for this project, Nuj Dalal headed this up. So you can see, like if you see A, B, and C, those are our 3 information flows. So the first one, A, the PROs, the notes, triggers, peak flows, all those are read in from the app to the app server, which is located within Brigham and Women's Hospital. Then the data is available in the dashboard in the tab in Epic. So that's one flow of information. That's A. B is when there's a request for call. That goes to a different place. That has to go to the nurse's EHR inbox, the in-basket message in Epic. So we configured it. That was clearly the only way that it would be scalable. The nurses were very clear that it had to go to the nurse assigned to that patient. And if it did, then they'd get the message and they would call the patient. And we've had a number of calls, and that seems to be working reasonably well. Then C, we also learned in our design sessions that in order to increase the likelihood that patients and doctors were actually going to have a conversation about this, we needed to tell both parties that there was data there and that you can bring it up if you want. So you don't have to bring it up, of course, like maybe there's other priorities, but we want to let people know that it's there. So for that, we had to have our app server read the appointment dates on a regular basis, and when there was an upcoming appointment, we actually do a push notification to the app and send some visit tips, very short tips, just saying, for your visit, remember you can bring your app, you can discuss it with your doctor if you're having any asthma questions. And then we also sent another in-basket message, this time to the PCP the night before, which just let them know that patients in the study, and they might have, and especially if they've had asthma issues. So this is a kind of a first attempt. We're looking into whether this worked, or whether they actually had discussions. But that's what came out of the design sessions, is likely to maximize odds that they'll talk about it. So all this is nice and good, right? We have this whole remote monitoring intervention in place, and then COVID happened. Kind of out of the blue for everyone, including us. So then this is a blog post that we published in the Health Affairs blog, where we make the argument that symptom monitoring, especially in COVID-19 era, but even beyond that, it really should be a universal healthcare function, not just for asthma, but for other conditions as well. And everyone should really have some at least regular check-in, because there's all kinds of benefits to it. And we took the opportunity with some supplemental funds from AHRQ to modify our app and our intervention to make it COVID relevant. And one motivation for this is we actually, in our survey of PCPs, we asked them this question: are you more or less or the same interested in digital remote monitoring in the era of COVID-19? And you could see somewhere around 2/3 or something like that are more interested. More than half are much more interested. A lot of the same level of interest. So that gave us some additional motivation. We made some tweaks to the app. Here you can see on the left anytime the patient wants, we added this COVID-19 screener. So it's already in their workflow. So whenever they have any symptoms, they can just click that. I don't know if any of you have participated in all of these monitoring COVID studies. I was filling out one every day for a while. I mean, all these, it's lots of benefits for them, but some of them there was questionable whether it was actually helping the patient. This actually helps the patient make a decision if they need to go in or not, and could provide secondary data as well. So we also we nudge them in this middle screen here, like if they requested a call, we said, well, one more thing, maybe check to see if you have COVID-19. They don't have to. The nurse would probably check on that anyway, but we wanted to flag that in case they were interested. And then also in our Learn tab, we added COVID-19 and asthma, which is, the knowledge on that is evolving. And what's nice is as it's evolving, you can just keep updating it. So once we have this kind of plumbing in place for this type of remote monitoring workflows and in the patient's hands, making these tweaks is not, relatively easy. Now, we also learned some things about recruitment, and this was recruiting primarily, actually entirely during the pandemic. And these are preliminary results; they're not final, but we're still recruiting. So we had, and I would say we're like we didn't follow the same exact process for every patient. So we're not ready to come to firm conclusions with this, and we're still analyzing it, but this gives some idea. So there's some patients we sent letters, but we didn't send any other messages to, and we had a very small number actually sign up. For our patient portal, some we even before we were going to got a chance to send them a letter, they got the patient portal message and they signed right up. A good number, decent percentage of that. Quite a bit more when we did the combination of letter and portal signed up, and letter and phone call was a smaller percentage. It seems pretty clear that having a patient portal helps a lot when it comes to signing people up, or there's an association there. It's there's not necessarily cause and effect. And then the biggest amount was letter, phone, portal, and phone call. That's how we got the most number of patients so far. And we did this really, I think, novel thing. We actually put in our in the asthma tab, if the patient's not enrolled, we made it really easy for the provider to just click one button and send a message to us. And we've trained a bunch of physicians, and we've already gotten 50 referrals. But somehow we haven't managed to convert too many of those, which is interesting. We're still looking into that because we thought that would actually help a little bit more than it did. So we're still looking into that. For in-person, we did try to do some in-person, especially as the COVID-19 restrictions started to roll back, and we haven't managed to consent anyone from a good number of attempts. And that we might try again, but I think patients are pretty eager to get going once they finish their visit or before their visit because of social distancing, not used to interacting in person. So that might be a barrier there, but we might try that again as things loosen up even more. So I want to give a few tips for these types of interventions for people that we've learned, some preliminary tips. One is to use the NAS framework. We found it extremely helpful, continually reminding us to keep things simple along a number of dimensions. The second is to make sure you have strong support for clinical leadership. We had that from the very beginning. And when unexpected things happen, the clinical leadership can advise on what's really happening on the ground. The third is to engage as many frontline physicians as possible in the design and planning, and they'll help you make sure that it's high value and low burden. Our PCP survey was helpful for that. Even if you can't interview every single one, getting their input somehow is useful, and also helpful, like showing them what the study's about. And then recruitment is clearly, and I think others have said this, but as many methods as possible is really the way to go. And then, of course, when new things happen, it's important to stay flexible. And as practice habits can, as we know, evolve quite rapidly, and there's a need to adjust. So with that, I want to thank my team. I have a large multidisciplinary team at Rand and Brigham, and some other institutions as advisors too who've contributed to this. And with that, here's my contact information. Always happy to discuss with this and answer questions or get ideas from people. And with that, I will switch the presentation back to, I think, Amal.
Great. Thank you, Dr. Rudin. And thank you again to all of our presenters for their very informative presentations. This concludes the content portion of the webinar, and we'll now have a few minutes left for questions. You can type them into the Q&A box to the right of the presentation slides. And although we may not be able to get to all of the questions today verbally, we will provide written responses to all questions, and you will receive an email once these responses are available. And now I will pass it over to Arlene, who will be moderating the Q&A session.
Thank you, Amal. First I really want to, thank all of the presenters for really outstanding presentations on really critical topics. And, I think it just shows the potential of digital healthcare solutions in really helping us deliver a high quality, equitable, effective care to people, but how far we have to go. And I think the importance of the ACTS Collaborative to bring people together to accelerate change. And I think also COVID, which really has been a great catalyst for innovation and enabling us to really move forward. And we know, I think there's so many questions right now in the Q&A. I have lots of questions for you, so I'm going to be brief. But we know that there's just so many barriers to making this part of routine practice, as some of you have alluded to. So, in some of the Q&A, it's like, how do we move this forward to the next step? And as you know, I'm the AHRQ lead for the developing the interoperable electronic care plan. And so we've encountered many of these challenges. So I'm well aware of what the challenges are. And I think, we're going to find solutions together. And it's great to hear what you said. So I'm going to start actually with a question for Dr. Osheroff. So there has been so much work on standards, there's been federal initiatives, collaborations, and we still have a long way to go for the future vision that you've created. Why is it taking so long, and what can we do to accelerate the progress?
Thanks, Arlene. That is a critically important question. I mean, obviously, people have been working on this for a long time. Certainly, data interoperability, especially, but more recently, knowledge interoperability. I think of it like trying to assemble a very large, very complicated puzzle. That's sort of what we're trying to do. And this LHS and the quintuple aim is the picture on the puzzle box. And I think a lot of the challenges have to do with the fact that the puzzle is large and complicated. So, for example, I think all the people who are working on the different things haven't agreed to date on what exactly the picture on the puzzle box is. So yes, quintuple layman learning health system, but what exactly does that mean? What does that look like? So I think the lack of a shared future vision, which that's one of the reasons why I think we attracted so many people to the ACTS project, because people were interested in that. So figuring out how to get the puzzle pieces to actually fit together. It's not just getting two puzzle pieces fit together. The standards need to apply around the cycle, and there hasn't been a focus around the cycle so far. And I think a lack of urgency also, which the, even though there are all these problems, people are just sort of working on them in silos without a major push. And I think COVID is a major push. So between what COVID has done and, the kinds of things we're trying to do in the ACTS work, as you've outlined, will hopefully accelerate all the great work that's happened in the past and finally help us put this puzzle together.
Thank you, Jerry. And my next question is for Dr. Krist. What steps could practices that cannot create FHIR applications? We know that a lot of primary care practices are not ready to do this. So what can they do to anticipate decisions, prepare patients for making a decision, and creating a care plan? And there was also another question in the Q&A related to this one, and this, for both you and Dr. Rubin, is how easy is it to adapt your application to other EHRs?
Yeah, those are great questions. I mean, I'm actually going to take a quick step back in that, I think on a national level, I've been advocating, and I'd love to see like the functionality that we're talking about kind of being out of the box systems for, health systems and clinicians to not have to create a FHIR app or not configure their systems to be compliant and have national guidelines in it and make care proactive and those types of things. I think it's really important to push nationally for all of this to be kind of plug and play functionality. I think with the Cures Act and with more of the information sharing that's occurring over the next 5 years, we'll see more and more apps and other things that groups can essentially purchase or subscribe to or turn on or turn off, like your smartphone, which might be able to do some of these functions within different systems. So then now getting to your question though, about what can systems do that sort of don't have this right now, as I was saying with the pandemic, we took some very simple measures using some of existing functionality within our systems to send messages out to larger numbers of people. In some cases, they weren't filtered messages. So like when we tried to reach out and say, hey, you really should think about getting the COVID vaccine, it's safe, and I believe in it. We weren't able to say, okay, well, who had it and who had not had it and kind of filter it that way, but kind of couching messages to be general so that they're encompassing everyone, but still action oriented can help. There are paper ways of doing things too, and trying to have people do things paper-based, mailing things to patients. That's certainly a lot of work and beyond the scope of what primary care can do, but a lot of us are behind schedule. So certainly as people are waiting for a doctor or someone to come in, is a chance to do things to be primed and prepare for visits. So even thinking of those simple workflows. And then the last question you asked about, like, could some of the apps that we're working on, I'll let Rob speak for himself, but certainly with my preventive care, I was quite impressed with Epic that when we created our integration, we could go in and see all the different Epic EMRs, and we could link it to those so that a patient, if being patient directed, and a patient could just say, with giving their permissions and their username and their password to the account, they could use the system. And that's where I'm saying I think we're going to see an emergence of more of these types of applications that can function on existing information that would be widely disseminatable on a national level.
Thank you, Alex. Bob, here's another question for you. Do you think the pandemic accelerated or slowed down progress in your remote monitoring intervention?
So, initially, I think the short answer is both. It accelerated progress in a sense that I think there was more recognition among the clinicians the importance, as we saw from their survey responses, and the clinics are quite engaged and interested in doing this type of work. But I do think it did make it more challenging to recruit patients in some ways, at least some types of patients, especially the in-person, the ability to recruit in person. And there's some patients who are really hard to get a hold of on the phone. And we found this particularly problematic during election season, when so many people were calling them for election-related issues, and it was hard for them to know who was calling. So I think it kind of cut both ways, in a sense. In the long term, I'm optimistic that the patient barriers will decline, and I'm hoping the clinician barriers will, the clinician facilitators will continue.
Thank you. So I think this one is primarily for Alex, but I would like Bob to weigh in too. Most patients have multiple chronic conditions, and I think, the promise of this is to get everybody's, all of their needs and diagnoses and goals together in one place ultimately. So, how do your apps, kind of feed into that patient-centeredness? And how do you address, do you have a separate app for each condition, or how do you eventually pull all this together?
Yeah, I think, oh, you want to go first, Rob?
I'm happy to go. If you want to go, that's fine.
Bob, either way is good with me. Whatever you'd like, Bob. You're unmuted. You start.
Okay, so we've always from the beginning taken the approach that this app is a stepping stone, or you could call it a building block. So if any patient who has multiple conditions, they're not going to have separate apps to manage them. That's just not feasible from a patient user experience. So at the same time, from an intervention design perspective, taking the hardest, most complex problem first is probably not in the long term the best approach for getting to your ultimate destination. So we're trying to learn as much as we can for asthma, which is arguably it's not simple, but it's probably simpler than many other conditions in terms of the requirements. And we've learned quite a bit for asthma, and we're also doing similar work in rheumatoid arthritis, and have a list of conditions that we hope to expand it to. But ultimately, absolutely, they should be all integrated. The patients should be able to answer questions related to the conditions that are relevant to them. It should dynamically update based on changes in their medical condition. And I think that's kind of the ultimate vision. And I hope we can get there soon, but it's going to be a few steps along the way.
Yeah, I think one of the nice things about your app is the data visualization, of the symptoms for people. And, one of the things, even though you're just focused on asthma, often some of those patient-reported outcomes and symptoms for people with multiple conditions, reflect the sum total of everything that's going on with them. So I think that might be another way down the road to do that. So, Alex?
Yeah, and I mean, I love your question, Arlene. And going back to that National Academy of Science, Engineering, and Medicine report, one of the first kind of guideline or recommendations, it was about payment, but I actually think the concept about care embedded in it is most important. And the recommendation was to pay for teams caring for people, not clinicians taking care of diseases or providing services. And that gets to your whole person care bit. And actually, I think to some extent in some of the pilots we were trying to do around prostate cancer, we liked that because there was this very specific educational tool we could provide to individuals. It was a nice pilot from that concept. And the feedback we got was, well, this is nice, but if it doesn't resonate with that person at that time, it's not very helpful, and we need everything. The My Preventive Care tools more broadly include all of the different preventive services and even extending into chronic care. And then more recently, which we've been doing some testing around patients creating care plans around health behaviors and mental health and social needs. And we actually have an array of 20 to 30 different things that people may have. And you know, at any point in time, people have somewhere between 4 and 8 different needs in those different domains around mental health, social needs, and health behaviors. And one of the approaches that we've taken is that we've been letting people kind of decide, what is it that's important to you and what do you want to work on? And so one of the outcomes we're looking at with some of that other work is, well, what is it that people pick? What matters to them and why does it matter to them? But I think some of that is the patient-centered focus. And it's very easy as a clinician to see someone and to see all those unmet care gaps and to be thinking, I need to close these care gaps. And that's what we're thinking about. But having a patient-centered approach where we can go and let people kind of find their needs, identify what's important to them, think about what they want to work on at each point in time, I think is probably really critical to address this, because so many people have so many needs all the time.
Thank you. So there's a couple of questions in the Q&A about whether this will be available on the website, the recording and the slides. And I want to reassure everybody that yes, in several weeks, they will be available, and feel free to share them with colleagues. I'm going to switch to equity, which is a really huge concern. And, you know, we know about the digital divide. We know about health inequities, both in access to care, health status, quality, outcomes. You know, it's pervasive. And I think some of these digital solutions, if they work just for those who can use them and are computer literate and have access, could actually widen health inequities. So what do we need to do? And I think this is for both Alex and Bob, as we develop these things, to make sure that they can be tools for promoting equity in healthcare.
I think the equity issue is critical. And in that National Academy report, there's a whole section on this. And, you know, the whole challenge with equity here is that, I mean, there is some element of kind of workflow and health systems and how we're doing things. But I mean, this is a national effort too. So, you know, there's elements like ensuring that everyone has broadband and access and promoting literacy and those types of issues. But going back to like that other care planning study that we were doing around social needs, you know, we have very, very simple things where we've tried to link people with tools and not just always rely on digital health, but to have lots of different pathways to make sure that we're meeting people based on where their needs are. And so we have navigators who will reach out and actually do a lot of the things that needs to be done for people. But it's amazing to me the number of folks who have no internet access, they don't have email accounts, they don't have smartphones, like none of those things exist. And you can see how digital health solutions are not going to meet their needs. So it's very important to realize that any kind of digital health solutions we create, we also have to have other pathways that are going to make sure that they're going to help everyone. And then we need community and state and policy systems in place to try and continue to close those digital divides and to help everyone move along in these areas.
So I completely agree that it's absolutely critical. And to me, the only way we'll have any hope of addressing it is if we consider it right up front, upstream in the design process, and design it with as many in as inclusive a way as possible. And that's not to say it's going to completely solve the problem, but it's an absolute requirement. And we've tried to do that with our design sessions, and we're trying to learn as much as we can about the barriers in terms of our implementation. You know, we are learning that, you know, there are more barriers with people who are you know, certain populations who are, you know, less tech savvy. But I think part of the emphasis that I think hopefully came across in my talk is that we're trying to keep it simple. So the simpler you keep it, the design and the actual you know, make it as usable as possible, that helps everyone. So I think the approach should be to try to kind of raise the floor for everyone. So like get everyone to a certain level. And it's Dr. Krist is absolutely right. There's going to be some gaps. Digital health is not the panacea for all health problems, but if you look at the numbers, a surprisingly large number of Low-income people have smartphones and use them regularly. Minorities and their numbers are going up. So it takes a while to develop these. So I mean, it's good to skate to where the puck is going to be and design them now, so we're ready to scale them later.
Speaking of which, Arlene, can I jump in for just a moment from a macro perspective on this? So when we started the ACTS project talking about the future vision 2.5 years ago, the focus was the quadruple aim. So that's what it was all about. We were trying to lower costs, improve quality and outcomes, and improve satisfaction for patients and care teams. Over the last several months, we very explicitly added equity, achieve equity, and bumped it up to the quintuple aim. So the whole notion of getting to the future vision, in addition to all the great sort of micro activities that has just been described, when we're thinking about the future vision and when we're thinking about the ecosystem that it's going to take to get there, equity is sort of baked right into it at the core, literally.
No, I think that's great that you've done that. Alex, there's a follow-up question in the Q&A for you. It says, do you assess health literacy or computer literacy when you invite patients to participate in a cancer screening decision through your portal?
We did not. I think we took a similar approach to what Bob was talking about and tried to design everything as simple and easy from the start. The other thing that we've done is we've created different variants in the past where we allow people to kind of toggle different versions, and we framed it more as detailed or versus sort of just the facts, and made it really easy for someone to pick kind of one level versus another level. Because we did get feedback where some people really want a lot of details, and that gets to be at a higher literacy reading. And so we had decided with a lot of feedback that we had gotten that just allowing users to kind of make a simple toggle like that was probably a better approach than doing some type of a formal health literacy assessment. Now, in our other social needs and mental health and health behavior care planning work, we are asking and doing an assessment on health literacy. We didn't use it to change the process. We actually are using it more as a or a variable in our sub-analyses, but we have navigators and people who are contacting the patients to start with, and they're making some of those assessments and helping guiding people through what works best for them.
So now I'm going to shift gears a little bit here. There's a really important question here in the Q&A, and maybe, this could be for any of you. How do we maintain privacy safeguards in an environment with ever-increasing data sharing and data access without stifling innovation?
Again, I'll take a high level whack at it real briefly. I mean, I think there's a push and pull. Obviously, privacy and confidentiality, things like that are incredibly important. There's a long history of laws protecting that sort of thing. And then, at the same time, the more we can have access to the data and use the data, the more innovation we can drive. So I think, at a high level, it's the notion of getting all the stakeholders together, getting all the issues on the table and figuring out what the pathway forward is to get to all the good things that we want to have happen and avoid all the pitfalls associated with exposing things that shouldn't be exposed. So collaboration, coordination, dialogue, I think, is the way to figure out what the right path is.
And Arlene, I'd say that I think that this is a national problem to figure out. In the National Academy report, there was we were advocating some for like a comprehensive database or real-time data exchanges. And here with the Cures Act, if you have the username and password, you can access any health information. I think I'm worried that our kind of model right now of relying on vendors and health systems to be the stewards of privacy and security is probably not the best long-term approach. There's certainly ways to do this. People talk about blockchain and other things, but there's lots of different strategies to protect information. But that probably needs to be kind of a national priority right now to come up with a very systematic approach that's going to work, but doesn't silo information and rely on kind of hiding information and not being able to access information as the solution for maintaining privacy.
Yeah, making a lot of complex privacy protecting requirements for innovators is probably not a good way to protect privacy or innovate. So I think the way to make progress is probably to have some established best practices that make it feasible to innovate and also maintain privacy. And I think we have a ways to go on that front.
Thank you. Okay. So I'm going to bring in a question, a comment from somebody from the patient perspective, who says, I hate being asked to pick one or two things to work on when I have multiple things that are causing me real problems. And I'm going to take us, because I think that's the really critical question as we really transform our system from taking care of diseases to taking care of people who have lots of diseases, other conditions, risks, and in the context of their lives. And I know with our e-care plan that we're working on, we hope to have a list of, sort of needs and goals and ability to do priority setting. I know Mary Tinetti at Yale has done a lot of work on patient priority care. And we do need to learn how to put this all together and develop a plan together with patients. So, that's my 2 cents, but I'll turn it over to you.
We've just put a note about patient priority care, referencing Tinetti's work in sort of the future vision. So that will be baked into the concept demonstration, how we make that sort of thing happen.
Arlene, I resonate with the statement from the person perspective there. Don't make me pick. And I mean, that's some of what we did actually, is we didn't make people pick. They can do all if they want. If they want to focus on one thing, great. If they want to do 3, 4, 5, 6, that's great. And, certainly as a clinician and a family doc, when I'm seeing someone, my job is to figure out what matters to them and deal with those things. And it's not to look at them and say, you're here for a visit and you only have one thing and we're only going to work on one thing. I mean, that's not patient-centered or holistic. And we really need to be thinking that way. So that it's an important question and viewpoint we need to embrace.
Yeah, I see we're just about running out of time, and there's so many more great questions that we have time to get to. But this one I'm going to ask to Dr. Osheroff about clinical decision support. And it says that much depends on the functionality within the vendors, EHRs, and many providers have alert fatigue and turn off these tools. Is there a particular CDS tool you have found to be most beneficial?
Yes, and it's not going to be what you're thinking. This is a great question. So over the last 15 years, we've written a series of books on improving outcomes with clinical decision support. And after we wrote the second one 15 years ago, I was trying to figure out, when we were giving talks about it, how to summarize what we were trying to express in these books. And it was basically clinical decision support is more than just popping up an alert in front of a physician when they're entering orders in a CPOE system. So 15 years ago, I articulated the CDS 5 rights framework, which basically says if you want to improve any care process or outcome, you have to get all the right information to all the right people through all the right channels in all the right formats at all the right times. So what I would offer is the most effective CDS. So a lot of people have used that framework. It's on board exams. AHRQ has it on their website and in their solicitation. So the powerful tool is don't think about alerts. It's sort of like using the guardrails on the highway to keep your car on the road. You can do that, but that's not the best way to do it. There's much better ways to inform decisions and actions than pop-up alerts. So in general, I would say a powerful tool is thinking about those dimensions and how to get to where you want to go through the right configuration of those 5 dimensions.
Thank you. We've reached the end of our time for today's webinar. Thank you all for attending. For those who are interested in obtaining continuing education units for participating in the webinar, please visit the URL shown on the screen. We will also be sending this URL to you via email. You will select today's webinar, which will be indicated by date and title, to claim your credits. You'll have 14 days to claim your continuing education units. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you'll complete the survey and share your feedback with us. Now back to Arlene to close out the webinar.
So thank you all very much for participating in this webinar today, and we hope you will join us for future learning opportunities. Thank you.